Good afternoon, everyone.
Good afternoon.
Good afternoon, ma'am.
Okay, my voice is clear?
Yes, ma'am.
Okay. Can you see slides?
Yes.
Yes, ma'am.
Okay. So yesterday I could not finish that Cushing syndrome, isn't it? So today I'll be a little bit talking, though I have already finished one slide of the clinical features. So today also I'll be starting with the same one. So we'll continue with the adrenal gland only. So now first we'll come to the clinical features of the Cushing syndrome. So this I have already told you, but still today I want to repeat. So in case of the Cushing syndrome, there will be the weight gain will be there. Weight gain will be there because there will be the central body accumulation of the fat will be there. So that's why there will be the weight gain will be there, and then the hypertension will be there. Hypertension because there is the renin angiotensin aldosterone mechanism will be activated, and then there is more of the water, and then the sodium absorption is there. That's why it will lead to the more blood volume and lead to hypertension. Understood? Yes. So and then there will be the mainly the weight gain is because of the truncal obesity. So in the body or in the trunk there will be the obesity will be there, but the limbs will be thinned out. So that's why their body or that feature will look like a lemon on toothpick. So lemon, when you put the toothpick from four sides, then central area is elevated or it is dilated or it looks fat, and then the toothpick it looks thin, isn't it? So the yes, please. Anything? Somebody telling me ma'am or what? So the feature will look like lemon on toothpick. So and then their face will be round and then very fat looks. That's why it will look like the moon face will be there, and then buffalo hump is there. Buffalo hump means and in the back, in the shoulder area, there is the increased accumulation of the fat will be there. So it will be known as the buffalo hump. So because of the protein catabolism, there is the atrophy of the muscles. That's why the limbs will become weak and then the thin. So because of the protein catabolism, atrophy of the muscles, proximal limb weakness will be there, and proximal myopathy, and then the limbs will look thin. So also because of the protein catabolism, there is the resorption of the bone. So resorption of the bone, and it will lead to the osteoporosis, and then the bones become thinned out and cortex will be thinned out. So it will easily lead to the fracture, isn't it so? So and also my voice is clear?
Yes, ma'am.
Okay. So because of the loss of collagen, the skin becomes fragile and then thin. So that's why whenever the skin is fragile, there will be the easy bruising will be there. Bruising means some scratches, or whenever somebody hits, there will be the something like reddish patches will be there. That is known as the easy bruising. And then in the body or in the hands also, or in the tummy or the abdomen, there will be the cutaneous stria will be there, and so usually that will be the purple and abdominal stria will be there. So it will look like purple. So that is known as the cutaneous stria. So coming to the other features, there will be the poor wound healing will be there. This poor wound healing is because of the decreased inflammatory response, and there is also, in case of the wound healing, you must have studied, there is the collagen deposition is there, isn't it so? So here the collagen synthesis is less, but the collagen breakdown is more. That's why it will lead to the this ulcer, and then the poor wound healing will be there, and then there will be the low immunity because inflammatory response is less. That's why there is the increased infection will be there, and it will also lead to the hyperglycemia. Hyperglycemia means the glucose level will be high, isn't it so? So these are all because of the cortisol effect in case of the Cushing syndrome. So here the glycosuria will be there. Glycosuria means sorry, glucosuria. Glucosuria means the glucose will pass in the urine, and then the more and more urine will go, so the patient will feel thirsty. That's why polydipsia is there. There is also the hyperinsulinemia. Hyperinsulinemia means here the insulin level, it is more in the blood, so that's why it is known as the hyperinsulinemia. That is the cortisol effect only. And then the insulin resistance. Insulin resistance means whenever the cells does not take up the insulin, so it becomes resistant to the insulin, so that's why it will lead to the hyperglycemia. So there is the mineralocorticoid effect also. Mineralocorticoid effect will also be there. That is also because of the high cortisol, and there will be the water retention will be there. Water retention together with the sodium, it occurs, isn't it? So sodium and then the water retention will be there. So that's why there will be the increased blood pressure will be there, or it will lead to the hypertension. And then potassium loss will be there. Potassium loss, that's why hypokalemia. So potassium loss, whenever these positive ions, it will be there in the body, that time the body will have the acidosis. But whenever this positive, like the potassium loss, isn't it? So these are the positive ions. So here the whenever potassium loss is there, so it will lead to the hypokalemia. So, and then in the adrenal androgen may also be increased, so it will lead to the acne, pimples, hirsutism in case of the females. Hirsutism means there will be the more and more hairy. So in case of the females will have less hair, so hirsutism will be there. And then the females can also have the menstrual irregularities. So there can be the hyperlipidemia. That's why there is the fat deposition is there. Hyperlipidemia will be there. And here, because of this high cortisol level, there will be the mental disturbances will be there. So mental disturbances means sometimes they will have the anxiety, sometimes they will have the depression, and sometimes even the mood swing will also be there. So poor wound healing, low immunity, hyperglycemia, leading to the glucosuria, polydipsia, hyperinsulinemia, insulin resistance, I already told you. And mineralocorticoid effect will also be there. Because of the sodium and water retention, blood pressure will be increased, potassium loss, hypokalemia will be there. And then adrenal androgen may also be increased, so it will show the acne, hirsutism, hairy in case of the females, menstrual irregularities, hyperlipidemia, menstrual disturbances, depression, and then the mood swing. So now in this picture, you can see here on the left side, a female having a very round face like the moon, isn't it? It's a full moon. So it is a moon shaped face. And you can also see here the stria in the upper picture where the abdomen is there, little bit bulging, central obesity is there. So there is the stria is there. So it is purplish in color. So in the just below that, the middle picture, you can see there is this is the buffalo hump. So there is the increased deposition of the fat in the back. So this is known as the buffalo. Buffalo, it has got very strong this back, isn't it? So similar to that one. So buffalo hump it is known as. So here, the female, it has got acne or some pimples you can see in the face. So, and she has also got more hair, isn't it? So hirsutism. So more hair it is there. So another picture also somewhat similar. So you can see here this central obesity is there. The picture on the left side, central obesity is there, and so more and more deposition of fat in the abdomen. And then you can also see the stria, abdominal stria is there. And then on the right side, you can see buffalo hump is there. And then there is also the pigmentation is there. Can you make out the pigmentation? Little bit blackish pigmentation. Because whenever ACTH is produced from the pituitary as a byproduct, this melanocyte stimulating hormone will also be produced as a byproduct. So that in case of the Cushing syndrome, there will be some pigmentation or the hyperpigmentation will be there. So same thing here. Signs and symptoms, central obesity, plethoric. Plethoric means, what do you mean a plethoric? Do you know the meaning of plethoric? Anybody? Here, plethoric means, I think somebody is feeling lazy and doesn't feel like working. So that is known as the plethoric. And then there will be the moon face will be there, acne will be there, and buffalo neck hump is there, and mood change will be there. So depression and then irritability will be there, and skin and muscle atrophy. That's why the limbs become thinned out, and then there will be the proximal weakness will be there. So as the muscle or the this protein catabolism occurs, there will be the proximal, this muscle weakness will be there. Bruises because of the skin becomes thinned. That's why the easy bruising will be there. Purple abdominal stria, osteoporosis, I already told you, hypertension, hyperglycemia, and gonadal dysfunction, that is irregular menstruation. Hirsutism, erectile dysfunction will be there in case of the male. So same picture. If you remember this picture, then it is easy for you to know the clinical features. So once again, I'll tell you: emotional disturbances, enlarged sella turcica, moon faces will be there, osteoporosis, cardiac hypertrophy is there, buffalo hump, I already told you, obesity, adrenal tumor, hyperplasia, thin, and then the wrinkled skin will be there, abdominal stria, amenorrhea, muscle weakness is there. Purpura. Purpura means because of this reddish patches, which is the petechiae means 1 to 3 millimeter. Purpura means little bit more than 3 millimeter in size. So the purplish reddish patches will be there. That is known as the purpura. And then there will be the skin ulcers will be there. Pore wound healing will be there. So now we'll come to the lab test. So here, in case, are you listening to me?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
Okay, is it clear? Okay, I'll just take the attendance, please. 87 students today. So now we will do the lab test, okay? So here mainly for the diagnosis of the Cushing syndrome, so lab test is the 24-hour urine cortisol. So whenever we will do the 24-hour urine cortisol, how much the cortisol is passing in the urine, so we'll collect the 24-hour urine and then we'll measure the cortisol. So if it is increased, then it is diagnosed that the person is suffering from the Cushing syndrome. Now to locate the lesion, now where is the lesion for having the Cushing syndrome? So we can locate the lesion also, or we can have little bit idea that where the lesion is there. For that location of the lesion, we'll give the one test is there, that is known as the dexamethasone suppression test. Okay, so dexamethasone suppression test is there. So here at first we will give the, you can see the flow chart.
Yes, ma'am.
Okay, so here for the dexamethasone suppression test, we will give the low dose dexamethasone is given. Understood here? First, you can see here where on the left side, the topmost area, low dose dexamethasone is given. And then whenever low dose dexamethasone is given and it causes the reduction in the cortisol, then this is known as a normal response. Understood here? Low dose dexamethasone is given, and then when it reduces the cortisol level, then it is known as a normal response. So now with the low dose of the dexamethasone, if the cortisol is not suppressed, then we will do little bit another test with the high dose of the dexamethasone. So here the high dose of the dexamethasone is given, and then if it causes the reduction in the cortisol, now with the high dose of the dexamethasone, if it causes the reduction of the cortisol, so it will indicate that the lesion is there in the pituitary. So it is knowing that the pituitary adenoma is there. So because of the pituitary adenoma, it is releasing the more and more of the ACTS, finally leading to the Cushing's disease. Understood? Yeah? So Cushing syndrome and Cushing disease, I already told you, isn't it? So whenever the cortisol level or the ACTS is high and finally leading to all these clinical features, that is known as the Cushing syndrome. But whenever this Cushing syndrome or the Cushing's condition is occurring because of the pituitary region, that time this is known as the Cushing's disease. So I told you also yesterday. So here pituitary adenoma is there. That's why it is known as the Cushing's disease is there. So now even with the high dose of this dexamethasone, cortisol is not suppressed. So now in this condition, the cortisol is not suppressed. If the cortisol is not it is not suppressed, so it may be because of the ectopic ACTS secretion, or it may be because of the adrenal tumor. So we have to find out where the tumor is occurring, isn't it? So now here then, now cortisol high dose, with the high dose of the dexamethasone, cortisol is not suppressed. So next step we will do the ACTS level. So ACTS level, we will see the test. So now the ACTS, whenever there is the ectopic ACTS, means whenever there is any tumor like the small cell carcinoma or the neuroendocrine carcinomas of the pancreas or any side, so those tumors will produce the hormones, isn't it? So that is the ACTS. So that's why in those tumors there will be the increased ACTS will be there. But if it is the adrenal tumor, then there will be the decreased ACTS will be there. Understood here? This flow chart, did you understand here? Yes, please, or no, I'll repeat once again.
Yes, ma'am.
Okay, I'll repeat the same one. So now we are talking about the Cushing syndrome, isn't it? So in the Cushing syndrome, usually for the diagnosis of the Cushing syndrome, we have to do the 24-hour urine cortisol. So whenever the cortisol level is increased in the 24-hour urine, then it indicates that the person is suffering from the Cushing syndrome. Now to locate the lesion, so we want to locate the lesion, whether the lesion is there in the pituitary or in the adrenal, or there is the paraneoplastic syndrome like the ectopic ACTS secretion is there or not. For that, to locate the lesion, we will give the dexamethasone suppression test. So here the dexamethasone is the steroid, isn't it? So dexamethasone suppression test we will do, and at first we will not give the high dose, but at first we'll give the low dose of the dexamethasone is given. So whenever there is a reduction in the cortisol, normally if in a normal response there will be the reduction of the cortisol will be there, so it indicates that the person is having the normal level of the this one, no tumor is there, so that is known as a normal response. So whenever with the low dose of the dexamethasone, cortisol is not suppressed. Okay, so you can make out in the chart, isn't it? So cortisol is not suppressed. So now in the next time we'll give the, in the next step, not time, we'll give the high dose of the dexamethasone. So whenever high dose of the dexamethasone is given, then whenever there is a reduction of the cortisol, then it indicates that the tumor is there in the pituitary. So there will be the pituitary adenoma. So already the Cushing syndrome or the Cushing's disease, isn't it so? So in case of the ectopic ACTS or in case of the adrenal tumor, with even with the high dose of the dexamethasone also, the cortisol is not suppressed. Understood here? In even with the low dose also, even with the high dose also, the ectopic ACTS or the tumor is producing the ACTS, or the adrenal tumor, it is releasing the ACTS, it will not suppressed. So now here we want to identify where the location of the tumor is. That's why we will do the ACTS test we can do. So usually the ectopic tumor, that is the tumor, and it is independent of this our pituitary, hypothalamic, all these adrenal, isn't it? So it is the tumor is in a different side. That's why it is all the time releasing the ACTH. So it is producing the hormone. That's why whenever it will show the increased ACTH, it indicates that there is the ACTH is producing from the ectopic tumor or from the tumor. Now, whenever there is a decreased ACTS, it indicates that the this ACTS is producing from the or coming from the adrenal tumor. Okay. Now understood? Yes or no? I'll go to the next slide.
Yes, ma'am.
Yes,
Okay.
ma'am.
Okay. So now we'll talk about the hyperaldosteronism. So aldosterone, what it is? It is a glucocorticoid or the mineralocorticoid. Aldosterone. It's a mineralocorticoid, isn't it? So here hyperaldosteronism is here. There is an increased level of the aldosterone or the mineralocorticoid will be there. So this zona glomerulosa will release the aldosterone or the mineralocorticoid. That I already told you in yesterday's class. So here the zona glomerulosa cells are there. So in case of the hyperaldosteronism, there is the increased level of the aldosterone is there. So aldosterone is a type of the mineralocorticoid, isn't it so? So this hyperaldosteronism, it may be of two types. One is the primary and another one is the secondary. So if it is primary, it is known as the Conn syndrome. Understood here? So it may be of the two types. One is the primary and another one is the secondary. If it is primary, it is known as the Conn syndrome. Secondary is for the because of the other reasons. So hyperaldosteronism, aldosterone is produced by the zona glomerulosa. So here in case of the hyperaldosteronism, there is the increased aldosterone or the mineralocorticoid will be there, and it is of two types. One is the primary, also known as the CON syndrome, and another one is the secondary. So now we'll go to the primary one. So primary or the CON syndrome, in the previous one, this table I have shown you. So now here it is the commonest cause, understood here. So hyperaldosteronism, primary tumor, primary secretion of this aldosterone, it is the commonest cause. So here for releasing of this aldosterone, there should be the adrenocortical adenoma should be there. So mainly the adrenocortical, this adenoma or this tumor is arising from the zona glomerulosa. So zona glomerulosa, it will produce the mineralocorticoid, isn't it? So it will produce the increased level of the aldosterone. So aldosterone, you know, by this time it will lead to the renin-angiotensin aldosterone mechanism, isn't it? So aldosterone main function is to lead to the sodium and then the water reabsorption it will cause from the tubules of the kidney. So there is the sodium and water retention, and so that's why it will lead to the increased cardiac output will be there. Whenever the blood volume will increase, definitely the cardiac output will also increase, and then there will be the increased blood pressure will be there, understood here. So there is a potassium loss is there. Here potassium loss is there because in exchange for the sodium, there will be the potassium will be there, isn't it? So that's why the potassium loss is there. So potassium loss is known as the alkalosis. Potassium loss, okay? Potassium loss is also known as it will lead to the alkalosis. So in the lab findings, so we'll find the low potassium because there is the loss of the potassium is there. That's why in the lab findings, we'll find the low potassium level, and it is the hyperaldosteronism, isn't it? So that's why it will show the increased aldosterone, understood here. So usually here the low renin will be there. You know why? Because here whenever aldosterone and then it is producing from the adrenal tumor, so here now there is the more and more water, this absorption is there, and then the sodium absorption is there that's why there will be the kidney will produce the low renin level. So primary or the CON syndrome, I'll repeat once. It is the commonest cause, and then there's for the production of the aldosterone, there should be adrenocortical adenoma. So the tumor is arising from the zona glomerulosa, and then it is producing or it is releasing the more of the aldosterone, so that there will be the sodium and then the water resorption will be more, or the absorption will be more. So it will lead to the more blood volume, increased cardiac output will be there. Whenever more volume and then increased cardiac output, so the blood pressure will be increased. So in exchange for the sodium, there will be the potassium loss will be there. So it will lead to the condition alkalosis. Whenever the potassium loss is there, alkalosis will be there. And in the lab findings, low potassium will be there. Definitely the aldosterone will be increased, and then there will be the low renin will be there. So now we'll come to the secondary hyperaldosteronism. So the secondary hyperaldosteronism, so here whenever there is the congestive heart failure or whenever there is the renal artery stenosis is there, what happens? So the blood flow to the renal tissues or the renal perfusion will be reduced, isn't it? So congestive heart failure, so here the heart cannot pump the blood properly, so it will lead to the congestive heart failure will lead the renal perfusion to be reduced, isn't it? So in case of the renal artery stenosis, so here artery stenosis means the lumen of the artery is stenosed or it has become smaller in size, so the renal blood supply will be less. So both these conditions will lead to the less renal perfusion or the less blood flow to the kidney. So that's why now whenever there is a less blood flow to the kidney will be there, so it will lead to the increased renin production, isn't it? So or the increased renin secretion will be there, so it will also lead to the renin-angiotensin aldosterone mechanism. That's why, so here the increased angiotensin is there, and then the increased aldosterone is there. So now here because of the other causes, not because of the tumor in the adrenal gland, but because of the other reasons, there is the hyperaldosteronism is there. So that's why this is the secondary hyperaldosteronism. So now we'll come to the difference between the primary and then the secondary hyperaldosteronism. So in case of the primary or Conn syndrome, there is low renin is there. There is a no edema is there. So whenever the renin is less, there is a no water and then the sodium absorption will be there. That's why there is no edema. But in case of the secondary hyperaldosteronism, high renin will be there and then the edema is there. So this much you understood? Yes? Are you understanding?
Yes, ma'am.
Okay. Do I have to repeat that slide once again? Secondary is easy only. So whenever congestive heart failure or the renal artery stenosis is there, so it will lead to the less renal perfusion. So whenever there is the less renal perfusion, that kidney will produce the more increase or the more amount of the renin. So renin will lead to the increased angiotensin, and finally there will be the increased aldosterone will be there. So difference between the primary and secondary: in primary, low renin is there, so there is a no water and then the sodium absorption is there. That's why there will be no edema in a person. But in case of the secondary, there is the high renin level will be there. That's why the marked edema will be there. So now we'll come to the adrenogenital syndrome. So now here, in case of the adrenogenital syndrome, this is the adrenal disorder which is characterized by the excess of the androgen. Understood here? So here there is the excess androgen is there, and then it will lead to the virilism. Understood here? So you know the meaning of virilism? So virilism means if in a female there will be the development of some like male characteristics, that is known as the virilism. Understood here? So like more hairy, like in case of hirsutism or the flat chest, these are known as the virilism. So now here it is an adrenal disorder which is characterized by the excess androgen hormones will be there, excess androgen hormone production will be there. So finally it will lead to the virilism. Virilism means, so here because of the hormone male, this androgen hormone, the female will show the characteristic features as that of the male, so that is known as the virilism. So now we'll come to the adrenogenital syndrome causes. So there can be the adenoma or there can be the carcinoma in the adrenal cortex. So this androgen is produced by what type of the cells in the adrenal gland or in the adrenal cortex? Zona, which one?
Reticularis.
Good. Okay, zona reticularis, isn't it? So here there should be the adenoma or there can be the carcinoma in the adrenal cortex, and then which will produce the more of the androgen. So mainly this tumor will be arising from the zona reticularis cells. Understood here? As you have answered also. So here mainly the zona reticularis is there, and then it will produce a tumor, adenoma or the carcinoma, and there will be the more and more of the androgen levels will be there. So, or there can be also the congenital adrenal hyperplasia also. So sometimes because of the congenital adrenal hyperplasia also, it can lead to the adrenogenital syndrome. Okay. So I'll repeat the slide once again. There is the adrenal disorder is there, which will show the excess of the androgen hormones, and then it will lead to the virilism. So causes for this are adenoma and carcinoma in the adrenal cortex. Mainly this adenoma or carcinoma to cause the adrenogenital syndrome. The tumor has to arise from the zona reticularis cells. So the zona reticularis cells will produce the androgen, isn't it? So another cause for the adrenogenital syndrome, that is the congenital adrenal hyperplasia. So it may be the congenital one. So it may be in the childbirth only. So now we'll come to the congenital adrenal hyperplasia. So congenital adrenal hyperplasia, this is also interesting. I found it interesting. So here it is a group of disorder. Understood here? So congenital adrenal hyperplasia is a group of disorder. So here we can see all types of the common features we can see. So mainly it is autosomal recessive disorder. So here a particular enzyme is decreased or absent. Understood here? So in case of the congenital adrenal hyperplasia, a particular enzyme is deficient or it is decreased in amount or totally absent. So here in case of the congenital adrenal hyperplasia, there will be the low cortisol level will be there, and then the low aldosterone will be there, but the androgen hormones will be increased. Understood here? So cortisol, it is coming from which layer? Zona fasciculata. Oh, good. Okay, zona fasciculata, isn't it? So here there will be the low cortisol level. Whenever there is the low cortisol level, it will lead to the increased ACTS production, isn't it? So that's why there will be the increased ACTS production, and then also the low aldosterone. So the mineralocorticoid is also reduced. That's why it will lead to the increased renin, and then the angiotensin production will be more. Understood here? So here, in case of the congenital adrenal hyperplasia, there will be, it is a group of disorders. Here all types of common features we can see here. So it is autosomal recessive disorder, and here a particular enzyme is decreased or it is totally absent. So here the different enzymes are there, but for you mainly this 21 hydroxylase enzyme you have to know. So here the low cortisol level will be there, and then the low aldosterone will be there, but there is the increased androgen level will be there. Understood here? So whenever there is a low cortisol level, then it will lead to the increased ACTS secretion, and whenever there is the low aldosterone, it will lead to the increased renin and then the angiotensin. So low aldosterone, definitely there will be the no sodium and water resorption will be there, and then low blood volume will be there, and then the kidney perfusion will be less, isn't it? So whenever there is a perfusion in the kidney is reduced, definitely the renin will be increased. So after the renin is increased, so angiotensin is also increased. So now you see here this chart, okay? So mainly here this cholesterol, it will change this pregnenolone and then the 17-hydroxy, this phosphate, and then the dehydroepiandrosterone will be there. So this cholesterol, it will lead to the pregnenolone, and then it will be converted to the aldosterone in the zona glomerulosa. So the 17-OSP, it will be converted to the cortisol in the zona fasciculata. Understood here? So this dehydroepiandrosterone, it will be converted into the androstenedione in the zona reticularis. Now you see here, whenever the hormone, this 21 hydroxylase deficiency is there, so at first usually it will be like this. Suppose this cholesterol, it will be converted to this pregnenolone, and then this pregnenolone will be converted into the 17-hydroxy progesterone, and then this dehydroxyepiandrosterone, and then after that this pregnenolone, it can be converted into the aldosterone, then 17-OSP can be converted into the cortisol, and then this can be converted into this one. So by this time you must be knowing that aldosterone, it is coming from the zona. Below you can see in the little bit strip like pattern, so it is coming from the zona glomerulosa, isn't it? So the cortisol is coming from the zona fasciculata. So this aldosterone or the androstenedione, these are the steroid hormones, isn't it? So it is coming from the zona reticularis. Now you see here, whenever there is the deficiency of a particular enzyme, I told you, isn't it? So it has got long several steps are there for, but from the pathologic point of view, for that all those steps is not necessary, but I don't know in biochemistry or in the other subjects. So here, whenever there is the deficiency of this enzyme, that is a 21 hydroxylase deficiency is there, so this cholesterol conversion to the pregnenolone, it occurs, but it cannot be converted to the aldosterone. So definitely the aldosterone level will be reduced, and then again this 70-hydroxy progesterone, it cannot be converted into the cortisol. So that's why it will lead to the decreased level of the cortisol. But this dehydroepiandrosterone, it will be converted into the androstenedione. So that's why this level will be increased. So in the previous slide, I showed you this one, isn't it? So now here there is a low cortisol level, low aldosterone, but the increased androgen is there, isn't it? So because of this diagrammatic picture, I wanted to make you understand. So there is the deficiency of the enzyme. That's why it will not be converted in the which needs this pregnenolone to be converted to the aldosterone, and then even to this cortisol also. So these levels will be reduced. So now here the most common enzyme defect is the 21 hydroxylase. So here there is a 21 hydroxylase deficiency is there, understood here. So that's why there is a low cortisol. The same thing I'm repeating, low cortisol. That's why there is the increased ACTS secretion is there, and so it will lead to the adrenal hyperplasia. So ACTS. So in case of the ACTS, what happens? So ACTS will act on the adrenal gland, so it will lead to the adrenal hyperplasia, and then the low aldosterone. So whenever aldosterone is there, so it is the mineralocorticoid. That's why there is the loss of the sodium and then the water, and then the potassium high will be there. So whenever there is the high androgen level will be there, it will lead to the virilization. Virilization, I already told you that whenever the female, they will have the more male sex hormones, male hormones, so it will lead to the male characteristics in a female. So it will lead to the virilization. So now we'll come to the different types of this congenital adrenal hyperplasia. So there are the 3 different types are there. So first one is the salt wasting is there, understood here. So salt wasting means there is the loss of the sodium and then the water is there. That's why it is known as a salt wasting, and it is a classical type. So here, in case of the salt wasting or in the classical type, there is a complete absence of the hydroxylase is there. Understood it? So there is a complete absence of hydroxylase, that is the 21 hydroxylase is there. So there is the marked mineralocorticoid and then the cortisol deficiency is there. So here it will lead to the mineralocorticoid and then the cortisol deficiency will be there. So that's why there will be the low sodium will be there, high potassium will be there. Whenever the low sodium will be there, and that's why there is a salt wasting is there. And then this potassium is high, isn't it? So whenever these positive ions will be there, so it will lead to the acidosis. So this salt wasting system, or the classical one, it is recognized after the birth, and then it will show the virilization in case of the females. So here there will be the virilization in the females, and some cardiac problems will also be there. And in case of the second one is the simple virilization syndrome. Here there is the partial loss of this hydroxylase enzyme is there. So here there is no salt and the water loss will be there. So here no salt wasting will be there as in case of the first one. And the third one is the non-classical type, that is the late onset type. So here there will be the non-classical type. It is not classical, that's why there is the late onset is there, and it will show the patient will be often asymptomatic will be there. Means for a certain duration of the time, patient will not show any signs and symptoms. So often asymptomatic will be there, but it may show only the features of the androgen excess during the puberty. So during puberty time only, it will show the androgen hormone is excess in level. So now I'll repeat the same slide. Salt wasting. Salt wasting is there, wasting is there. So it is a classical type. There is a complete absence of the hydroxylase is there. Then there is the marked mineralocorticoid and then the cortisol deficiency is there. That's why there is a low sodium and then the high potassium will be there. And salt wasting is there, acidosis is there. And it is often recognized soon after birth. Okay. So here virilization is seen in case of the females. And then there is the cardiac problem will be there in case of the salt wasting or the classical type. And in case of the simple virilization syndrome, there is the partial loss of the hydroxylase will be there. Okay, so there is the partial loss of this enzyme is there. So that's why there is the no salt wasting is not there. But in case of the non-classical type, there is the late onset. This is the late onset. So the patient will become, or the person will become often asymptomatic. They are asymptomatic, but it will show the features of the androgen, excess of the androgen during the puberty. So during puberty, it will show the person is having the excess of or more of the androgen level. So now we'll come to the adrenal insufficiency. So coming to the adrenal insufficiency, so there are the two types are there. One is the primary and then another one is the secondary. So the primary, it is acute and chronic, and then the secondary is there. So adrenal insufficiency, it means Addisons disease, isn't it? So whenever this adrenal gland, it will show the this insufficient amount of the hormone production. So that time it is known as the Addisons disease. So it is of two types, primary and then the secondary. So the primary, it is divided into the acute, and another one is the chronic. Chronic is also known as the Addisons disease. Are you listening to me? My voice is clear?
Yes, ma'am.
Yes.
Okay.
Yes, ma'am.
So now we'll come to the primary or the acute type. So here cause, there is a sudden withdrawal of the exogenous corticosteroid treatment is there. So whenever this primary acute adrenal insufficiency occurs, so here the first will be there. So now whenever there is a sudden withdrawal of the exogenous corticosteroid treatment is there, so whenever we give the treatment to the patient with the steroid treatment, we do the tapering of the dose, understood here? So here whenever there is a sudden withdrawal of this corticosteroid, exogenous corticosteroid, so it will lead to the adrenal insufficiency. So it is the primary and then the acute type. So in this case, there is the massive adrenal destruction is there. So there is the massive adrenal destruction is there. So here there will be the massive hemorrhage in the adrenal gland, it will be there. So mainly you will see this in case of the newborn after the prolonged and then the complicated delivery also. Whenever the female will have this prolonged and complicated delivery will be there, sometimes there will be the massive hemorrhage in the adrenal gland in case of the newborn child will be there. So in case of the DIC after surgery, so DIC means, do you know the meaning of DIC? That is the disseminated intravascular coagulation, isn't it so? So here, whenever there is a prolonged surgery is there and then the tissue damage is there, so the tissue necrosis occurs. So later on, it will lead to the disseminated intravascular coagulation. So here, both these coagulative system will also be activated as well as the fibrinolytic system will also be activated. So DIC after surgery. And now you see here this adrenal insufficiency can occur also in case of the sepsis and then in case of the septicemia. So sepsis and septicemia mainly because of the Neisseria meningitis and then the meningococcal infection. So whenever there is this occurs, so there will be the massive hemorrhage in the adrenal gland will occur, and then that time this is known as the Waterhouse-Friderichsen syndrome. So now whenever this adrenal gland is destroyed because of the massive hemorrhage by or due to this sepsis or infection by the Neisseria meningitis or the meningococcal infection, that time the condition is known as the Waterhouse-Friderichsen syndrome, understood here? So this Waterhouse-Friderichsen syndrome is more common in case of the children. So here the bilateral hemorrhagic infarction of the adrenal gland occurs. So there will be the adrenal gland hemorrhage will be there, but in the both of the glands it will occur because the infection will not cause into one adrenal gland, isn't it? So that's why there will be the bilateral damage of the adrenal gland will be there. And so here there will be the rapid hypotension and then shock will be there. And so it is emergency. So if the patient is not treated urgently, then the person can die. Okay. So here the patient, it's an emergency condition. So it has to be treated urgently. Otherwise it becomes fatal and the patient may die. So primary or the acute type, I want to tell you once again. So here primary or the acute, this adrenal insufficiency. So here in the first cause you see sudden withdrawal of the exogenous corticosteroid treatment here. So whenever there is a sudden corticosteroid treatment is withdrawal or it is stopped, then the now the ACTS how much it has to be secreted, it will not be produced. So it will lead to the massive adrenal destruction. So massive adrenal destruction, it can be seen in case of the massive hemorrhage in case of the newborn when the delivery is complicated and it is prolonged. So also in case of the disseminated intravascular coagulation after surgery, and also in case of the sepsis or septicemia. In case of the sepsis and septicemia leading to this massive hemorrhage in the adrenal gland is known as the Waterhouse Federation syndrome. So mainly here the bacteria is responsible, especially Neisseria meningitidis and then the meningococcus. So it is more common in case of the children, and both the adrenal glands, it will be hemorrhagic and then infarction occurs. So whenever this hemorrhage, massive hemorrhage and then infarction occurs, so it will lead to the hypotension and then the shock will be there. And so it is emergency condition. So the patient has to be treated urgently. Otherwise, in most of the cases, it is fatal. So now we are coming to the primary agent. Is a primary, it is of two types. One is the acute and another one is the chronic type. So now we are coming to the primary chronic type, and it is also known as the Addison disease. So here, in case of the Addison disease, there is the adrenal cortex, whatever hormones it is releasing. So 90% of the cortex is destroyed. So that's why there is the no more hormone releasing will be there, or very less will be there. So now definition, destruction here, to have the Addison disease, there is a destruction of the adrenal cortex more than 90% understood here. So there is the low aldosterone from the zona glomerulosa will be there. So now here there is also the low cortisol from the zona fasciculata will be there, and then the low androgen from the zona reticularis will be there. So here whenever the adrenal cortex damage is there or the destruction is there more than 90%, then it will lead to the low level of the aldosterone, cortisol, and then the androgen. So low aldosterone from the zona glomerulosa, low cortisol from the zona fascicularis, and then the low androgen from the cortisol from the zona fascicular, and low androgen from the reticularis. So etiology, idiopathic. Idiopathic means the cause is not known, isn't it? So idiopathic means the cause is not known. So another one, etiology or another cause is the autoimmune adrenalitis. So now here, because of the auto antibodies, so it will attack on the adrenal gland and it causes damage of the adrenal gland, leading to the autoimmune adrenalitis, finally leading to the Addison's disease. And even sometimes the infections like the tuberculosis, fungal, or in case of the AIDS also, the adrenal gland or the adrenal cortex will be damaged. So here, that's why infection, TB, fungal, and AIDS also will lead to the Addison's disease. So sometimes the metastatic carcinoma, whenever the metastasis or the tumor from other side of the body, it goes and then it gets deposited in the adrenal gland. That time also it will lead to the destruction of the adrenal gland, finally leading to the primary chronic type of adrenal insufficiency or the Addison's disease. So I'll repeat the slide once again. So there is for the primary chronic type or the Addison's disease, there is a destruction of the adrenal cortex, and then here the destruction is more than 90% of the cortex. There is the low aldosterone from the zona glomerulosa, low cortisol level from the zona fasciculata, and then the low androgen level. So here every hormones will be reduced, aldosterone, cortisol, and then the androgen. So whenever these hormones are reduced, this is known as the Addison's disease, isn't it so? So coming to the etiology, cause is not known. One is the idiopathic and another one is the autoimmune adrenalitis. So here the autoantibodies will attack on the adrenal gland and it will cause the destruction of the adrenal cortex. Sometimes even the infections like the tuberculosis, fungal, or the AIDS will also cause the damage of the adrenal cortex. And in case of the metastatic carcinoma means whenever the tumor metastasizes to the other parts, like in case of the adrenal. So here, whenever the tumor deposit is there in the adrenal gland, that time also the adrenal cortex will be damaged, finally leading to the Addison's disease. So now we'll come to the features. So Addison's disease is it will show the slow onset. So here there is the low aldosterone will be there, low cortisol will be there, and then the low adrenal androgen will be there. So now here whenever low aldosterone will be there, what happens? So aldosterone, it is a mineralocorticoid, isn't it? So there is, whenever low aldosterone will be there, so that there will be the no water and then the sodium absorption will be there. So here the same thing, sodium and then the water loss will be there. That's why weight loss will be there. And then whenever the water and then the sodium is not there, definitely the low BP or the low blood pressure will be there, and then the person will have the postural hypotension will be there. So postural hypotension means if a person is sleeping and then lying down and then suddenly gets up, that time the blood pressure becomes low. That is known as the postural hypotension. So whenever this, now this low blood pressure or the postural hypotension, it will lead to the low perfusion in the kidney. That's why it will release the increased renin, and then the increased angiotensin will be there, and then there will be the increased potassium will be there. Now the sodium absorption is not there, definitely the potassium will be there, so that's why it will lead to the acidosis. Now coming to the low cortisol, there is the increased ACTH and its precursors. So low cortisol, there is the increased ACTH will be there and its precursors. So whenever the cortisol level is increased from the pituitary, ACTH will be increased and its precursors. So because of the increased ACTH, I told you in case of the Cushing syndrome also there was the pigmentation, isn't it so? So there will be the increased pigmentation of the skin will be there, because as a byproduct of the ACTH, there will be the melanin secreting hormone will be produced. That's why there will be the increased pigmentation of the skin will be there. And low cortisol, it will lead to the hypoglycemia, and then there will be the poor response to the stress. And in case of the low adrenal androgen, there will be the decreased libido will be there, and even the adrenal gland may show the lymphocytic infiltration. So now we'll come to the features once again. Looks like I will not finish. So these features tomorrow I'll tell you, okay? One more, the secondary hypoaldosteronism is also there. So today's class also I could not finish. I will upload the yesterday's class, but today's one I will not. So from the features, we'll repeat once again, or the Addisons disease also we can repeat once again. Now, do you have any questions? Sahamat Ahmad, are you there? Looks like he's not there. Lokraz, are you there?
Yes, ma'am.
Okay, did you understand the class?
Yes, ma'am.
Okay, do you have any questions?
No, ma'am.
Okay. Rustam, I like this name.
Yes, ma'am. Yes, ma'am.
Okay. Do you have any questions?
No, ma'am.
Okay. It means that all of you have understood. I don't think so. Apurv. Are you there, Apurv?
Yes, ma'am.
Anything you want to know?
What, ma'am?
Do you have any questions?
No, ma'am.
Okay, then. Okay, thank you so much then. So I'll upload the first slide, and then today's slide also I could not finish. Then tomorrow I'll take the class, and then that time I'll upload. Hope tomorrow I'll finish both the classes. Okay?
Thank you, ma'am.
Okay.